Next, we will have the keynote speech. Today's keynote speaker will be Dr. Shimon Sakaguchi, Distinguished Honorary Professor at Immunology Frontier Research Center, Experimental Immunology of Osaka University, who was awarded the Nobel Prize in Physiology or Medicine last year. Now, Dr. Sakaguchi, the floor is yours.
Well, first, I'd like to thank the organizers of this symposium for inviting me here to speak. So title of my talk, it is Innovative Research, Startups and the Translation into Society. Actually, this title was offered by the organizer, but which audacious. So I'd like to more talk about the regulatory T cells, that is, prospects of regulatory T cell, Treg cells for treating cancer and immunological diseases. So let me talk about a bit more like academic side, and then following me, Mr. Mike McCura, the CEO of RegCell, we are working together. He'll talk about more business side as startup. So as shown on this slide, there is a paradigm shift, smaller, big, in our thinking of how to control desirable or undesirable immune responses. For example, previously, until recently, the drugs, for example, immunosuppressive drug, that's all targeting the effector T cells mediating immunological diseases such as autoimmune disease or allergy. So how we can reduce the number of effector T cells or reduce their function. So if we reduce their function or number, it is good for treatment of autoimmune diseases, allergy, or preventing organ rejection in organ transplantation. On the other hand, by strengthening them, we can increase efficiency, efficacy of microbial immunity or tumor immunity. So various drugs such as steroid or calcineurin inhibitors, or more recently the co-stimulation blockade such as abatacept or betaracept. I forgot the name, but there are nice, good drugs, but all are antigen non-specific. So as a result, you may see various adverse effects. For example, the infections after treating with autoimmune other immunological diseases with targeting effector T cells. So effector T cells all are dampened. Now, recently, the regulatory T cells, they were found, and they are suppressing the immune responses in almost in every immune response. For example, they are responsible for the preventing the development of autoimmune disease or allergy, or they can prevent organ rejection in transplantation. And on the other hand, if you reduce Treg, then you can enhance antimicrobial immunity or anti-cancer immunity. And so now there is a good possibility that by targeting Treg, we can control immune responses in a physiological fashion. So that is what we are doing, and we hope that this is it has just started. So we hope that in the future, good drugs or good way of treatment, or the expanding Treg or reducing Treg or enhancing their function or dampen their function. And by these ways, the more efficiently we can control the disease and prevent the various diseases, or even prevent cancer development. So what is important here, what's the difference between these two approaches? That is Treg, they are T cells, so they can recognize antigen. This means that without antigen recognition, they cannot be activated or they don't suppress. So this means that we can establish antigen-specific suppression, which cannot be achieved by the previous approach. By this the induction of antigen-specific suppression or tolerance, we may be able to the better way of more safer way of treating the various immunological diseases and also cancer. So outline of my talk today is, first let me talk about how Treg were found, and then how they look like, how they function, and then the molecular basis of their suppressive function, especially in relation to autoimmunity and tumor immunity. And then let me talk about how we can treat autoimmune disease by antigen or disease-specific regulatory T cells and convert it from disease-mediating T cells. So what we plan to do, and also as a startup, that is we are aiming at antigen-specific suppression efficiently. And so we believe that one way is if we can convert disease-mediating T cells into Treg, so bad guys into good guys, that is the best way of antigen-specific suppression, because effector T cells, they recognize the target antigen and doing bad. And then, now they can be converted to good guys and now suppressing the immune responses in a disease-specific or antigen-specific manner. So let me first, how Tregs were found. So here on this slide, this is a feature of immune responses. So every immune response, it can be characterized as the T cells and B cells, which can react to diverse antigens. And also, they have a high antigen specificity, and they have immunological memory. And so once you have a viral infection, for example, measles, you don't have the next infection, because the immune cells, they possess immunological memory. And then potent mechanisms of antigen elimination, such as the antibody can neutralize viruses in the circulation, and also T cells can destroy virus-infected cells. So these characteristics of the immune system, it is very good to fight against viruses or bacteria. But once it turns to self-tissue, causing autoimmune disease, and because of these properties, it's hard to cure or prevent the disease progression. So one of the important features of the immune system, that is unresponsiveness to self-antigen. And then at the turn of the century, Paul Ehrlich, Nobel laureate in 1908, he published one paper, and then in that paper, he coined the term horror autotoxics. So the immune system is not supposed to react with self. But to do that, there must be important regulatory contrivances, regulatory mechanisms. So the research of that, the mechanisms, that is very important. So here, let me talk about autoimmune disease as an example. It is supposed that approximately 8% of the population is afflicted with some sort of autoimmune diseases. For example, in the brain, multiple sclerosis, thyroid gland, Hashimoto's thyroiditis or Graves' disease, and then stomach, autoimmune gastritis, adrenal gland, Addison's disease, and type 1 diabetes in the pancreas, And then also ovary, it's a cause of a premature ovarian failure responsible for the infertility in young women. And also systemic autoimmune diseases such as SLE or rheumatoid arthritis. So in immunology, so the important question is how these autoimmune diseases develop. So in other words, how dangerous lymphocytes and T and B cells, which are potentially reactive with self, how they can be controlled. So in history, there are three major mechanisms have been proposed. One is deletion. So very dangerous lymphocyte, when they are generated, when they recognize self-antigen, they'll die by apoptosis, so they are deleted. Then second hypothesis is the lymphocyte can recognize self-antigen, but they cannot be activated without co-stimulation, a second signal. Just looking at the self-antigen, then they become inactivated. They don't die, but they become inactivated, not functional. We call them anergy. And third mechanism is even the normal individuals, they do possess a potentially hazardous lymphocyte reactive with self-antigen. But there is another population of lymphocyte which can actively suppress the expansion and activation and expansion of such dangerous the lymphocyte. It is called suppression. So for immunologists, it has been challenging to show which mechanism, if it's become abnormal, doesn't work, whether these diseases in humans, do they develop by as a result of abnormality of these mechanisms. So which mechanism is if we manipulate, can produce these human autoimmune diseases, in similar to human counterparts. So what we showed many years ago, that is indeed this mechanism, third mechanism of suppression. If you remove regulatory T cells from the immune system, you'll see these autoimmune diseases. Just simply let me show you the experiment. It's not so complicated. Just here, normal mice, there's spleen. There are lots of T cells and B cells, 30% T cells. So if you make a T cell suspension, and if you suppose that among them, there must be a suppressive T cells. And if you can remove that suppressive population and then transfer the remaining cells into T cell deficient mice. So B cells are there, but the T cells are absent. And if you transfer 4 T cells, of course, nothing happens. But if you remove a certain population, and if you then transfer the remaining cells into these T cell deficient mice, and then if they develop autoimmune disease, that population is important suppressive T cells present in the immune system. So various molecules as markers, we try to remove that population or this population, and then whether autoimmune disease happens or not. And then what we found, what we ended up is this marker, CD25. So here, CD4 positive T cells, so 30% of splenic T cells. And then among CD4 positive cells, 10% express this molecule called CD25. And you can remove this population by antibody plus complement. So you can kill these lymphocytes. And then after removing this population, and if you transfer to T cell deficient mice, indeed, they developed various autoimmune diseases. So just if you transfer 4 T cells, nothing happened, no autoimmune disease. But if you remove CD25 positive cells, and then the remaining cells are transferred, 100% stomach, autoimmune gastritis, ovary, autoimmune ovulitis, thyroiditis, 70%, salivary gland adenitis. It is like a human Sjögren's syndrome, 45%, and adrenalitis, like a human the Addison's disease. And then the type 1 diabetes, and glomerulonephritis as seen in human SLE, or arthritis as seen in human rheumatoid arthritis. And importantly, if you add back removed population, now you can prevent disease development. So this was a key experiment to show that the regulatory T cells are present in healthy individuals. They are actively suppressing the development of autoimmune disease. So based on these mechanisms and these findings, our current understanding is that, so from the bone marrow, the T cells come to the thymus, and then they proliferate, and then if they strongly react with self-antigens. So self-antigens, ubiquitous one. So every cell has an enzymes for example, glucose metabolism, whatever. So if the lymphocyte happen to react with such abundant or ubiquitous self-antigen, they'll die. But what we know is that the potentially hazardous T cells causing autoimmune diseases, perhaps they have a lower affinity for self-antigens, but they can survive and then migrate to the periphery, and then they are present in our body. And also the thymus produces regulatory T cells specialized for immune suppression. So Treg control the self-reactive T cells and preventing autoimmune disease. And if you reduce the number of Treg, now they become activated and cause autoimmune disease. So that is current our understanding. Then the next question is, so whatever it is, if the environmental anomalies or insults or genetic anomalies which affects the balance between suppressive T cells and then disease-causing T cells, they can be causative of these immunological diseases. And so environment, the certain virus more actively infect the Treg. For example, in humans, HIV can infect CD4 T cells, especially at an early stage, the regulatory T cells. So you'll see the HIV immune deficiency, but at early stage, you'll see autoimmune phenomena. And the chemical, cyclosporin A. So CD25 is an ALT receptor. So cyclosporin A can reduce Treg. So sometimes after using cyclosporin A, you may see autoimmune phenomena. And then Tregs are very much the proliferative because they are always looking at recognizing self-antigen and proliferating, meaning that they are radiosensitive. So split dose by X irradiation can reduce them, and then you can cause autoimmune disease. So these environmental causes, and then plus genetic anomalies. So there are many monogenic autoimmune diseases, and many of them are now they are supposed to affect regulatory T cells. And the most important one is the FOXP3. In the last year Nobel Prize, the co-laureate is they are Mary Blanco and Fred Ramstel. They cloned the gene called FOXP3. So these two people, they worked at a startup company, and then they thought that there is a disease called IPEX syndrome. So one gene defect, and you'll see autoimmune disease, and type 1 diabetes, more than 80% of patients, thyroiditis, more than 70%, and also other autoimmune diseases, and almost 100% inflammatory bowel disease. So the babies, when start having milk feeding from the mother, and then intestinal bacterial flora develop, and then immediately they show inflammatory bowel disease, and also hyper IgE and allergy. So when they are weaned and then taking food orally, then immediately they show food allergy. So they thought that one gene, if you characterize that gene, then you may be able to understand how autoimmune disease happens, how inflammatory bowel disease or allergy happens. So that's a very challenging but exciting the endeavor. So they clone the gene, and then now it is called FOXP3. So there is the mouse strain show a similar disease, and then both have disease gene is on the X chromosome. And then, so this is the scurvy mice, similar to human IPEX syndrome. And then FOXP3, if you stain them, 10% of CD4 positive cells, they are expressing FOXP3. And then a mutant of FOXP3, and scurvy mice, they don't. And then 2 years later, we showed that, well, so they couldn't show how this gene defect causes autoimmune disease or allergy or inflammatory bowel disease. But we know that by removing Treg, you'll see autoimmune disease, IBD, and allergy. So we co-stained FOXP3 and CD25. And this is a marker we found as the Treg specific marker. So you see that majority of FOXP3 positive cells, they are CD25 in the spleen, also in the thymus. So we show that CD25 we removed the CD25 positive cells. This means a majority of FOXP3 positive cells, they were removed. So we could induce autoimmune disease. So now to define regulatory T cells, FOXP3 in the nucleus and the CD25 on the cell surface, that is the most they are most important markers in humans and also in mice, in rodents. So here, just summarize, by removing Treg, and then transfer into T-cell deficient mice, we could see autoimmune disease, inflammatory bowel disease, and allergy. And then here, IPEX syndrome. So the disease gene is on the X chromosome. So mother, XX. So the half of the regulatory T cells, they are intact, but the other half defective. So the remaining intact Treg can actively suppress disease development. So mothers are healthy. But here, the patients, mainly male kids, because they have only one X chromosome. So if they have a defect, the Tregs are dysfunctional or they don't develop. And you see the autoimmune disease, inflammatory bowel disease, or allergy, just similar to what we see in mice. So the dominant immune self-tolerance, active suppression of immune responses, that mechanism is really responsible for the autoimmune disease or other immunological diseases in humans and also animals. So conceptually, what is important is the following. The potentially hazardous autoimmune T lymphocytes are present in every healthy individual, but under dominant suppression by Tregs. Second, the border between self and non-self is not fixed, but movable by controlling the number and function of Treg. So self, non-self, immunological self or non-self, and that is a kind of the kind of cliche words in immunology. But the border between self and non-self is not fixed; it's more fuzzy. So this means that autoimmune disease can be treated, tumor immunity evoked, and transplantation tolerance established by controlling the number or function of regulatory T cells. If you reduce the Treg, you see autoimmune diseases such as diabetes and thyroiditis as seen in the IPEX syndrome, or immune responses against commensal bacteria in the intestine. So you'll see IBD, inflammatory bowel disease, or environmental substances, the allergy. So the tumor immunity, by reducing them, I've shown that autoimmunity happens. But how about tumor antigen? Kind of the tumors, cancers, they develop from self. So tumor antigen is a kind of a quasi-self, self-like the antigen. So it's easy to induce anti-tumor immune responses by reducing Treg. So here, T-cell deficiency in the mouse, and then if you inoculate tumors, and if you transfer Treg depleted cell population. So they develop autoimmunity. But at the same time, they show strong immune responses against cancer cells inoculated. So first tumor become bigger and then rejected. So after rejection, if you inoculate 10 times the number of tumor cells, same tumor cells, then you see immediate immune responses, very strong one, like a measles virus infection. So this means that you can induce the immunological memory to your autologous cancer cells. So if you don't remove Treg, so Treg suppress immune responses. So tumor grew bigger, and then the mice died of tumor progression. Just the opposite way, if you increase the number of Treg, now you can suppress the non-self immune responses, such as the immune responses against the organ transplant. So here again, T cell deficient mice, no T cells. So you can easily they'll accept the skin graft from the another strain. White mice or black mice, and if you transplant the skin graft from a black color mice. So and then if you inoculate normal T cells, and then immune responses happens. So here dotted lines, 100% accepted. But if you transfer T cells, now rejection happens. So within a month, all are rejected. But if you first transfer Treg, so within a week, they'll come to the graft and then proliferate, and then suppress the T cells, the inoculated 1 week later. So you see the rejection become prolonged, and then 30% show permanent acceptance. And if you increase the number of Treg, now 70% of the mice, now they stably accept the graft. So this means that without immunosuppressive drug, just make Treg expand, then you can induce transplantation tolerance and stable transplantation tolerance. So historically, we show that Tregs are present, and then they can be defined by CD25 as a molecular marker. And then the Mary Blanco and Fred Ramsdale, these two people show that FOXP3 gene is important, and they clone the gene. And then we showed that the Treg and the FOXP3 CD25 all can be CD25 and the FOXP3 can define Treg. And then after that, this is a publication, number of publications per year. The papers working on Treg now rapidly increased. And then these 25 years, now we have a better understanding of how Treg functions, or how they develop, and also how they can be applied to treat the human diseases. So let me briefly talk about their function, Treg function. So what is important is that if FOXP3 gene is introduced into normal T cells, they can be converted to FOXP3 positive cells, and then they show Treg-like suppressive activity. So here I've shown that if you deplete Tregs and then transfer the remaining cells into T cell deficient mice, you'll see autoimmune diseases. And then in this case, if you co-transfer with FOXP3 transduced T cells, what would happen? Well, so they can suppress disease development. For example, colitis, IBD can be suppressed, or autoimmune gastritis can be suppressed. As shown here, the normal colon, colitis can be prevented by FOXP3 transduced T cells, or stomach. So theoretically, any immunological or autoimmune diseases can be treated by induction, say, gene induction of a FOXP3. But as you may know, gene therapy is a bit dangerous because we cannot control where the transduced gene, the incorporated. And sometimes you see a cancer. So What we are now, what we're doing, perhaps Mike will talk about later on, that is, without genome manipulation, how we can convert the normal T cells into Treg-like suppressive cells. So no genome manipulation, just hitting signaling pathways, how we can convert them into a functionally stable Treg. So just briefly, FOXP3 controls this Treg suppressive function, and which downstream gene is important for a Treg suppressive function. So the simple idea is, if you knock out the downstream gene, which one develop the FOXP3 scurvy, FOXP3 mutant-like severe autoimmune disease. So FOXP3 mutation causes autoimmunity, and then only 4 strains, they developed severe autoimmunity. One category is IL-2. So here, FOXP3 upregulating CD25, this is IL-2 receptor, but at the same time, they suppress the IL-2 production. So Tregs are highly dependent on exogenous IL-2, so IL-2 knockout or CD25 alpha chain or beta chain knockout, they all show the very severe autoimmunity. All happens also in humans. There are several families in the world they show they possess this kind of a mutation, and they show the very severe autoimmunity. And then another one is CTLA4. So CTLA4, as you may know, ipilimumab, as shown by Jim Allison, it is good for the cancer immunotherapy. But people, as I talked about with my first slide, the people thought that CTLA4 may be expressed by effector T cells. So and they should block CTLA4. Now they break to the effector cells blocked. So the effector cells can the more vigorously attack cancer cells. That was the old idea. But now we know that the regulatory T cells, the FOXP3 positive cells, they are highly expressing CTLA4. So if you remove the CTLA4 from the Treg as conditional knockout mice, so FOXP3 positive cells are here, but they don't express CTLA4. Then these mice spontaneously develop very severe autoimmune diseases. For example, autoimmune disease in the heart, myocarditis. So there is the cellular infiltration into myocardium, and then the heart become bigger because of heart failure. And then other autoimmune diseases such as gastritis and thyroiditis happens. And in the circulation, you'll see the high concentration of IgE, meaning that they are prone to develop allergy, and tumor immunity. So they'll die. So if you transfer T cells into another mice and then inoculate the tumor cells. So red lines, conditional knockout mice, CTLA4 deficient, Treg specific CTLA4 deficiency. They show good immune response, and then tumors are rejected. On the other hand, normal one, they cannot reject. So this is our current understanding that the Treg, FOXP3 expressing, suppress IL-2 production, but upregulate IL-2 receptor. So they absorb IL-2 from the surroundings. And then also FOXP3 upregulates CTLA4 and then control the CD8086. And this is a co-stimulatory molecule. And what happens is that the CD8086 is reduced. So responder T cells, they can recognize antigen, but they don't have co-stimulation called signal 2. So signal 1 and signal 2 can activate T cells. Just signal 1 alone, they may die by apoptosis, or they become non-functional energy, or just stay dormant, depending on the affinity of the antigen and T cell receptor. And then more also importantly, CD8086 downregulation upregulate free PD-L1. And this is free PD-L1. It is free PD-L1 which can interact with PD-1 and put into negative signal. So the anti-CTLA4, ipilimumab, anti-PD-1, nivolumab, or anti-PD-L1. Now these are the immune checkpoint blockade antibody, now widely used in the clinic. But the mechanisms, how they control immune responses, it is still controversial. And what we've shown is that the Treg-dependent immune suppression, and then each step can be controlled by these monoclonal antibody. So as a result, as you may know, anti-ipilimumab or nivolumab, adverse effect is always autoimmune disease or inflammatory bowel disease. And then we know that by manipulating Treg, we can induce allergy, autoimmune disease, and IBD. And indeed, these Treg signature molecules, such as CTLA-4, they can be controlled by these antibody. So the current cancer immunotherapy, anti-CTLA-4, it is blocking or cell-depleting or soluble CTLA-4 neutralizing. So these one antibody has various effects, but commonly reduce Treg function or number, and also activate effector cells. As a result, good tumor immunity and also autoimmunity. And the PD-1 antibody, sometimes it activates Treg, but also they more potently activate effector cells. So as a result, good tumor immunity, but sometimes autoimmunity. Now we are developing a CCR8 antibody. It's a chemical receptor. So CCR8 is only very selectively expressed by tumor-infiltrating Treg. So by this antibody, this is cell-depleting. We can deplete Treg, the tumor-infiltrating Treg, but not other tissues. So we don't the Treg reduced, but the effector cells not much affected. And then Tregs in other tissues, normal tissues, they are not affected. So good tumor immunity, but no autoimmunity. So this antibody is now under clinical trial in various countries, including the United States, Japan, and also China and Europe. So in the future, the current immunosuppression, immune checkpoint blockade, it is effective. Especially the anti-PD-1 plus anti-CTLA-4, more effective, but more serious autoimmune disease. So, but just reducing immune checkpoint blockade, well, for example, by depleting Treg, reducing the Treg number by anti-CCR8, and then low dose of anti-CTLA-4 or anti-PD-1, maybe that may be safer than the current protocol of cancer immunotherapy. So now the last part of my talk is about how we can suppress immune responses. So Treg cell therapy now under trial in many countries. So the estimated around 200 clinical trials are ongoing in the United States, also mainly in the United States and also in Europe. For example, in 2025, around 100 clinical trials they are planned or underway. So these trials, they are targeting Treg, natural Treg, which are present in our body. So you can, as I said, they can be defined by molecular markers such as CD25 or FOXP3. So you can select how you can selectively expand Treg by inhibiting effector cell activation. So low dose IL-2, because Tregs are highly dependent on IL-2. So low dose IL-2, which is not enough for activating effector cells, but it's enough for expanding Treg. So the various the approaches to expand Treg in vivo, and also you can take them out and then ex vivo, you can expand them with antigen stimulation plus IL-2, and then transfer back to the patients. And then you can also manipulate the engineer Treg with a CAR construct, and then make them efficiently migrate to the particular inflammation site. So the many startups are now trying to make the natural Treg more effective more efficiently migrate to the inflammation site. So lots of activities are ongoing. And what we are doing now is that, as I said, the most effective way, ideal way of antigen-specific suppression, that is to convert effector T cells into Treg in vivo or ex vivo. How we can achieve this conversion, that is what we are doing, and also our startup company, Rengcell, is doing. So idea is the effector cells, reactive with self-antigen causing autoimmune disease, alloantigen, and then the transplantation organ rejection, or allergen to cause allergy. So retaining the antigen specificity, if we can convert such effector cells, can convert it to FOXP3 positive Treg, retaining the same antigen specificity. That is kind of one of the ideal ways of immune suppression, antigen specific suppression. So how we can achieve this? So the T cells, we know that natural Tregs present in our body. We know how they develop. So a transcription network, including FOXP3, and also epigenetic configuration. These together important. So FOXP3 bind to the particular gene, but binding site, that must be also modified to accept to bind, allow the transcription factor bind to that state. So epigenetic modification plus transcription factor network, both are important. And then if both can be installed into antigen-specific T cells, you can convert them into Treg. So how we can induce transcription factors. And then let me talk about how we can install epigenetic modification, just briefly. So this is our recent study with the CRISPR-Cas9 genome-wide screening. So human CD4 T cells, 20,000 genes, almost all genes, and then you can put guide RNAs, and then delete at random delete genes, and then after that you can induce Treg, and then if the FOXP3 higher or lower ones, and then you do sequencing, and you'll find that which gene can upregulate FOXP3 or downregulate FOXP3, and then upregulated one here, RPBJ or HDAC3, and then it turned out that the RPBJ, NCOL1 or HDAC3, this is called the producing a repressor complex and suppressing the FOXP3. So this is the one target. So this kind of approach is now available, and we are looking at the candidate genes by this technology. And also chemical screening. We screened 5,000 chemicals to mainly the tyrosine inhibitors or serine threonine inhibitors. And which one can induce FOXP3? Just a 3-day culture, just put in these substances, and 3 days later, whether FOXP3, the Treg specific transcription factor, can be induced or not. So it is known that the TGF-beta can induce FOXP3 from naive T cells. But effector T cells, now disease-mediating T cells, it's difficult to convert to Treg by TGF-beta. But this compound, the AS, this is the artificial compound, it can induce FOXP3 even in effector memory T cells, also from CD8. And so now we know that the key transcription factor FOXP3 can be induced even in effector memory T cells. And how about epigenome? So here, the effector cells here, and how we can make them stable in epigenome. And what we found is that if you remove co-stimulation, it is called CD28 signal, and then you can induce Treg type epigenome. So here, natural Treg, so FOXP3, CTLA4, they show the white circle means demethylation, meaning that they are stable in gene expression. But TGF-beta induced conventional induced Treg, they are a bit FOXP3 positive. but methylated. These sites are methylated. But here, the induced Treg without co-stimulation. And now you see these stable epigenetic changes. So they are functionally stable. So we can induce FOXP3 and then also Treg type epigenome together. Now we can convert the disease-mediating T cells into Treg. So we call them natural Treg like stable and functional iTreg. So SF iTreg. So this is Pemphigus vulgaris, the skin disease, autoimmune skin disease. The one feature, key feature of this disease is that target self-antigen is only one. So desmoglein 3, which is expressed by a keratinocyte. So autoantibody against desmoglein 3 produces this kind of blisters, bullae on skin or also mucosa. So now it's an animal experiment. So desmoglein 3 knockout mice. And if you immunize with desmoglein 3, so T cells and B cells become activated because these mice, they don't express desmoglein 3. So desmoglein 3 is a new, novel antigenically novel to them. So they become activated if you transfer into the T cell deficient mice. So of course they are expressing desmoglein 3, and then you see this kind of blisters, and then autoantibody formation. And the idea is these desmoglein 3 specific T cells, when they are converted to SFIT in vitro, whether they can suppress disease or not. So here, day 7, now they develop disease, and if you inoculate SFIT, now you can suppress autoantibody formation, red lines, and then also a clinical score, no blisters, blisters such as this, and then no immunoglobulin deposition to keratinocytes. And then migrate these SFIT, desmoglein 3 specific ones, they specifically, selectively migrate to skin lymph node, not other places, mesenteric lymph node or spleen. And then in the skin, they become activated, expressing CTLA4 and show good suppressive activity. And then they show this is antigen specific because they specifically suppress the autoantibody, desmoglein 3 autoantibody producing B cells, not for B cells. So antigen specific suppression and then helper T cells called TFH, follicular helper, they are suppressed. As a result, the B cells are suppressed. So now in humans, so natural Tregs here, they are FOXP3 positive and also expressing CTLA4. And then now we can make the SFIT from the healthy individuals. They are highly expressing FOXP3, CTLA4, and they show Treg type epigenetic changes. And then gene expression profile is just like natural Treg, or even stronger in gene expression. And then the chromatin remodeling, similar to natural Treg, and then SFIT. So the protein expression, gene expression, epigenetic changes, all Treg-like features can be installed in disease-mediating T cells. So in Pemphigus vulgaris, now we plan to do some clinical trials and also other diseases. And importantly, even if we don't know the target antigen, for example, SLE, more than 10 target antigens are present. So we don't know which one is important, or this may be different among individual patients, but that's fine. Just if you can convert the patients' effector memory population they can be converted to Treg. And if you transfer back to the patient, and then those stimulated Tregs, they expand, and not stimulated ones, they don't expand. So eventually you can induce disease-specific suppression. And it's also the case with Crohn's disease, IBD. We know that T cells are involved, but we don't know what kind of T cells are involved. So, but still, that's fine. We can convert it anyway, activated T cell into Treg. So this is the last slide of my talk. So now we plan to do in humans, in patients, the disease-mediating T cells into Treg, and then treat them, using them to treat the disease. So today I have talked about Treg. They are naturally present, and also they can be generated in vivo and in vitro. So by strengthening Treg in number or function, you can treat autoimmune disease, allergy, or IBD, or organ transplantation, or fetal-maternal tolerance, the stable pregnancy. And then also by reducing Treg number or function, you can enhance immune responses as expected in the anti-cancer immunity or for treating chronic microviral infection. So many people are involved in these studies, and then also collaboration with the clinicians, and then also the scientists in other disciplines such as pharmacology. And then, so thank you very much for your attention.
Thank you very much, Dr. Sakaguchi.